Good morning. My name is Myra Gatlin Akers, and we're so glad you joined us today. I'm the regional manager for early detection and education with Mary Bird Perkins Cancer Center. Today we have Dr. Hopkins with us, and we're so glad that she took time out of her busy schedule to be with us. But we also we'll have an opportunity for you to ask questions, and you can do that in the Q&A or in the chat, and they will be answered at the end. Dr. Hopkins is a board-certified dermatologist and experienced physician practicing in Monroe, Louisiana since 1996. Dr. Hopkins opened her first private practice immediately after completing specialty training. After 4 years of medical school at LSU-MC Shreveport and 1 year at internal medicine internship at Ochsner Hospital, New Orleans, she received training in the field of dermatology through a progressive and competitive residency program with an emphasis on surgical and cosmetic dermatology at LSU School of Medicine in New Orleans. After 25 years of solo practice, Dr. Hopkins decided to expand her clinic. In May 2021, she opened a second location in Southlake, Texas, offering the same advanced, unique treatments in her new location she offers at her primary practice. One of those unique treatments includes image-guided superficial radiation treatment, a non-surgical cure for skin cancer that provides a 99.3% cure rate. Hopkins Dermatology is in the top 1% of dermatology practices in the U.S. offering this advanced treatment option. I'm proud to introduce Dr. Hopkins. She is very well respected in our area, and I'm going to turn it over to you now.
Thank you, Myra. I really appreciate the invitation to participate today in this webinar. Skin cancer is a very important part of my dermatology practice, and even to the point where I consider at some point we practice cutaneous oncology because we see so much skin cancer in both of my locations, both in North Louisiana, Monroe, and in the newer location in Southlake, Texas. And overall, if we're looking at statistics in skin cancer, there's been quite an increase over the past decade. There's been an estimated 35% increase incidence of the skin cancers, particularly basal cell and squamous cell carcinoma. And part of what we're experiencing is just generations of people who have participated in a lot of outdoor activities. Pretty much, I would say if you grew up in the 60s and 70s, you've got a pretty high risk of skin cancer because it seemed like the trend was baby oil and iodine and laying out. And then we had that generation who grew up in the 80s and the 90s when the tanning beds also became a thing as far as indoor tanning. And now the newer generation that we're seeing, and actually in the past couple of years, I've had quite a few patients, even in their mid-20s and late 20s, present with basal cell skin cancer and melanoma. And I think the incidence of increased skin cancer in that group is due to a lot of the outdoor sports and activities that the kids participate in. So I call that group the travel ball generation. And so they're growing up playing tennis, soccer, baseball, and just all that chronic sun exposure, unfortunately, is increasing the risk in even the younger group. So in dermatology, we basically see these three main types of skin cancers. There are other ones that are less common. If you remember, Jimmy Buffett recently passed away from what was called Merkel cell carcinoma. So there are some more rare skin cancers that we see, but the ones listed on this slide, the three main types, are ones that we see daily in my practice. Basal cell carcinoma is reported to be the most common cancer in the United States. We secondly see squamous cell carcinoma. And these two skin cancers both are derived from damage and mutations of the keratinocytes in the epidermal layer. So when the basal keratinocyte mutates, that would lead to what we refer to as basal cell carcinoma. And when it's more of the squamous keratinocytes that receive the UV damage primarily, and those DNA mutations occur, then that leads to what we refer to as squamous cell carcinoma. And these two present differently, both clinically, and they behave somewhat differently if we look at their risk. And I'll go into a lot more detail on that as we progress through the presentation. Third most common skin cancer, melanoma. This is, of course, a skin cancer that occurs from mutations of the melanocyte. And I'll explain more when we're discussing melanoma, why that puts these cancers at a higher risk for metastasis. So our skin cancer risk, I've mentioned a few of them already, but it's chronic sun exposure, it's acute sunburns, both excessive sun tanning with indoor tanning use. With tanning bed use, patients are actually getting exposed to UVA, and we know that UVA in particular can cause increased mutations of the melanocytes. So there's been definite documentation and statistic analysis that show patients or people who use indoor tanning beds are going to have a significantly higher risk of lifetime risk of melanoma. So we certainly try to educate people that they need to avoid both indoor and outdoor tanning. Sunburns, of course, are bad for our skin cells in that it can increase damage that could lead to further mutations, and that would increase people's risk for all three skin cancers as well. So besides outdoor environmental sun exposure and indoor tanning bed use, we also appreciate that there are risks based on genetic predisposition. So it's always important when I'm meeting patients for the first time and we're discussing their risk that we discuss, family incidence of skin cancers on both mom and dad side of the family. Multiple moles puts people at a higher risk for melanoma, 50 or greater. Then we're starting to, really get concerned that that patient may be at more risk for melanoma of these lesions. Weakened immune system, we know our transplant patients are significantly at higher risk for squamous cell carcinoma. And in my practice, I have over the years had multiple patients who've had transplants, and we see them very frequently because of their accelerated risk for squamous cell skin cancer. We even have protocols in place with systemic therapy to try to mitigate that, but unfortunately, their risks are quite high. And then we also know that people will be more at risk if they have, some of the genetic underlying risk factors. So these are just some common risks that we are screening our patients for. So let's kind of dive deeper into basal cell carcinoma. Again, as I mentioned, this is the most common cancer in the US. Thankfully, basal cell is curable and can be treated rather easily if we catch it early. So it's always best when we detect lesions that are smaller and we catch them early enough that we can do procedures and treatments to eliminate these lesions from continuing to grow and expand. Unfortunately, I have had patients who have presented with very advanced basal cell carcinomas that have been left untreated, and the risk areas would be around eyes, lips, nose, and ear, where it can destroy a lot of that surrounding tissue. And so early detection, again, with all of these cancers is really critical. If basal cell carcinomas are left untreated, they still have a low risk for metastasis. It's not a zero risk, but even more advanced basal cell carcinomas, when I've CT scanned patients looking for any positive or possible lymph node involvement, it's very rare that we do find a metastatic basal cell carcinoma. But I do have a lot of pretty advanced patients who will come in with lesions that are inoperable. And so thankfully, we do have systemic drug therapy available for basal cell carcinoma. And these typically fall under a category we call hedgehog inhibitors. And these are systemic drugs that can actually block the replication of the tumors and actually cause regression or result in regression. I've got several patients that we put through that type of protocol, but the side effects can be difficult. Typically with a hedgehog inhibitor or drugs such as Airovig, we have to consent patients that side effects may include hair loss, loss of taste, and leg cramps. And so when we use those to treat larger basal cell carcinomas or patients with multiple malignant lesions, we often have a limitation on duration, and then we'll often choose something like X-ray therapy once we've managed the tumor size in order to cure the cancer completely. So again, as I mentioned at the beginning of the talk, we actually are now even seeing younger people presenting with basal cell carcinoma. My youngest patient in my practice is 18 years old. He actually was one of the patients that had started playing t-ball at age 3 and 4, and then spent most of his youth at the ball field. And he was a very fair-skinned type 1 patient, and with multiple sunburns over his young life, he did present with a basal cell carcinoma on his left temple. We cured that cancer at the time with surgery, And actually a few years ago, he presented again in his early 30s with his second basal cell skin cancer. So unfortunately, when people have a history of skin cancer, they have a very high risk of developing more cancers throughout their lifetime on the skin. So I have several protocols in place that, again, we try to mitigate their risk with multiple, developing more malignant lesions over time. This is a very classic example on this first patient's nasolabial fold cheek area. In dermatology, we'll call this a pearly papule, kind of a description for basal cell. Typically, they're rather well defined. They're raised up above the surface of the skin, and they have a pink pearly color. And this would be certainly a red flag for a malignant lesion, basal cell carcinoma. But as you can see on the photograph below, this gentleman has a shiny pink spot. It's not quite raised. The borders aren't as well defined. And this would be another clinical presentation for basal cell carcinoma. Often, if left untreated, they will start to scab and bleed. And I always tell my patients, if they have any lesions that don't heal and scab or bleed, then they need to immediately call and schedule an appointment to have that lesion checked. Nowadays, a lot more patients come in for full body skin exams, not just when they notice there's a problem, but a lot of preventative skin exams. And I think everyone should get yearly skin exams. I was actually doing an interview yesterday, and the reporter asked me, well, who needs to see a dermatologist and have a skin exam? And I said, everyone with skin. So just like we go to the dentist to have our teeth checked to make sure we don't have cavities, and we usually start that in childhood, and we usually go at least once a year, I think the same thing would hold true for skin exams looking for early signs of skin cancer. And it also gives us an opportunity to educate patients on ways to avoid sun exposure and sunburn, such as daily use of sunscreen, reapplying sunscreen at least every hour and a half. And I'm a huge advocate of sun protective clothing. There's a whole textile technology where fabrics can be made that actually block out 98.6% of the harmful sun. And these will be labeled with a UPF, so it stands for ultraviolet protection factor of 50. And when you see shirts and hats and clothing that are made with its UPF 50 fabric, then again, that means that they had to validate that it would block out 98.6% of the harmful UVA, UVB rays. So for my golfing patients, my patients who play tennis, pickleball, people who are in the sun a lot, I really advocate that they wear those sun protective shirts as well as sun protective clothing with hats and even leg covering. So, started kind of with an interesting little story. A gentleman in Australia who was an avid marathon runner, and he developed melanoma. And he realized that here he was, this fit athlete, and he almost died from cancer because he was in the sun running marathons. So thankfully, the gentleman survived his cancer, and he went on to develop sun protective clothing for athletes. And so there's pictures on their website with him running his marathons completely covered with these fabrics and these clothings that are made of a light fabric that do block out the sun. So it's important that we go steps further than just putting on sunscreens at the beach or the pool or before we're going to go out and work in the yard, and really wear sunscreen daily, protecting even when we're driving in the car or running errands and just out and about during the day. Basal cell carcinoma, again, these are some examples, 4 different views of what they can look like. You can see the one here, I don't know if my pointer's showing on the slide, but the one in the top right corner, very ill-defined, but slightly irregular, slightly raised, but that would be an early basal cell carcinoma in a hair-bearing area. The one on the left top slide is a classic basal cell on the side wall of a patient's nose. The one on the bottom left is what we would call a sclerosing or morpheoform basal cell. Looks almost like a little scar or a little shiny, just red patch. Maybe there had been injury to the skin. So these sometimes can be overlooked more easily unless you are willing to look closer and kind of get more history from the patient. And in dermatology, the best thing is just always, when in doubt, take a biopsy. It's the simplest thing to do to either rule out or confirm basal cell or other skin cancers, just simply taking a sample or biopsy of the lesion, having a pathologist look at what the cells are doing at a molecular level. So these again are examples of basal cell carcinoma. Again, different types, we categorize them. Nodular, the most common, we see this often again as the raised lesion. Sometimes we'll catch things really early, more superficial, where they haven't become invasive into the dermis of the skin. Pigmented basal cells are often tricky. They typically get biopsied because there's a concern that could be melanoma. And you can see in this picture here where it would meet some of the melanoma warning signs with asymmetry, variations of color, irregular border. But thankfully for this patient, instead of being advanced melanoma, it was a pigmented basal cell carcinoma, and they respond to treatment just like all the other types of basal cell carcinoma do. And I'll explain later in the presentation the treatments that we offer for these types of cancers. Morphiiform and basosquamous cell carcinoma are just variations. The morphic form tends to be a bit more aggressive. These may be more likely to have deeper kind of roots and extensions, either further out or deeper down, and they have slightly higher risk of recurrence after surgery. Again, just showing more examples and photographs, hoping everyone can kind of pick up on these subtle and somewhat quite obvious visual changes that you see with these lesions. I don't think anyone would overlook the one on the bottom, but certainly the one at the very top could be a little bit more difficult to detect without really scrutinizing the area carefully. So the second most common skin cancer, now we'll switch over to squamous cell carcinoma. Myra, would you like to stop and ask questions now, or just wait till I finish the entire total presentation?
I think we'll just go ahead and go to the end.
Okay, great. Okay, so squamous cell carcinoma, as I mentioned in the beginning, is basically from mutations of the squamous keratinocyte. These will often give us a warning sign that we call actinic keratosis. These are precancerous lesions, the actinic keratosis. And when we say that to patients, and I explain to them what I mean, if we did a biopsy of an actinic keratosis lesion, we would see about anywhere from 20 to 40% of these squamous keratinocytes in the epidermal layer are abnormal. They're replicating too quickly, they're unorganized, they have mutations of their nucleus, but they haven't completely taken over the epidermal layer. Once they completely take over, then we would call that superficial squamous cell carcinoma, or another term we use quite often is squamous cell carcinoma in situ. And beyond that, then they become invasive into the dermal layer of the skin. And once the cancer cells go out of the epidermis into the dermis, then we consider that to be an invasive cancer. And squamous cell carcinoma actually accounts for the most skin cancer deaths in the US. People often think melanoma is the one that causes the most skin cancer deaths, but actually 4 times as many skin cancer deaths are related to squamous cell than melanoma. Now, we also see a lot more squamous cell carcinoma, so statistically speaking, a much higher percentage of skin cancer squamous cell carcinomas than melanoma, but these can be very tricky cancers. Thankfully, a few years ago, a company called Castle Bioscience was cleared for genetic mutation studies on melanoma skin cancers, as well as now squamous cell carcinoma. So I will often order a Castle Bioscience gene mutation study on a squamous cell carcinoma. We know that the people who have higher risk for metastasis and squamous cell carcinoma deaths have some kind of classic characteristics. Unfortunately, men, especially the seniors over age 70 with squamous cell carcinoma on the head and neck, are at higher risk for metastasis. Squamous cell carcinoma located on the temples and the lip and the ear are higher risk for metastasis. And then squamous cell carcinoma that are greater than 2 centimeters are higher risk. So those are some of the clinical warnings for higher risk with squamous cell carcinoma and metastasis. Histologically, there's several things that we can, that our dermatopathologists will report that could indicate the squamous cell carcinoma is more likely to metastasize. And those would be things like perineural invasion, poor differentiation, if there's a lot of even perivascular involvement. We know those squamous cells if they're around the vessels, around the lymphatics, then maybe they've also gotten into those highways and interstates and have spread to lymph nodes. So when we're reading histology reports on squamous cell carcinoma, it's not enough just to look at the final diagnosis. It's very important to read what the dermatopathologist is describing, because that's where you can, pick up on the fact that that might be a higher risk squamous cell carcinoma for metastasis. All of my dermatopathologists that read my slides do rate them well differentiated, moderately differentiated, or poorly. And always moderate and poorly differentiated squamous cell carcinomas are going to get screened with this Castle Bioscience gene mutation study. And it's a very interesting test because it literally tells us whether the squamous cell carcinoma, and this is also true for melanoma, has a high or low risk genetic mutation. And they'll rate it as a class 1, 2A, or 2B. And a 2A squamous cell carcinoma will likely have around a 20% chance of metastasis. So those patients in my practice are going to get a CT scan of their head and neck if that's where the tumor is located. And often I'll also consult an oncologist just to get on board. The reason to get that baseline CT scan is if the report comes back as a class 2A and it's a 20% chance of metastasis, I need to know if the patient already has a metastasis. And typically it would be to the lymph node. So we do a lymph node exam, we do CT scans of, again, head and neck is the most common area. And again, I would want an oncologist to be on board and on my team as far as monitoring that patient. We don't necessarily treat those cancers any differently. The treatments are going to be basically either Mohs surgery or image-guided superficial radiation therapy. But if it is a more high-risk squamous cell, oftentimes the oncologist and I might decide to also use adjuvant therapy. If it's a 2B for sure, because then again, we're almost at a 50% chance that patient's had a metastasis or will within the first 3 years of diagnosis. So in a 2A or 2B, we want to monitor them more often. They come in for skin exams like every 3 to 4 months instead of every 6. And then again, if it's a 2B with a 50-50 chance, and they have a clear baseline CT, I still have to be highly concerned that they could still have a recurrence or metastasis within the first 3 years. And that patient might qualify to take Keytruda or Libtayo, one of the immune therapy drugs, in conjunction with oncology. And we will detect sometimes patients who've already had a positive node and that they need to have lymph node dissection. So squamous cell can be quite tricky, and we have to be, more heightened awareness of who's at higher risk, which of these squamous cells could act badly and come back to give patients problems if we don't really address all this on the front end of the diagnosis and treatment plan. Some examples, these are again, kind of classic squamous cells. You see this one on the top of the helical rim, just looks like a little bump. Maybe it's starting to scab. Patients are kind of scratching them sometimes or picking, they bleed. Obviously, warning sign would be bleeding of a lesion. The one on the bottom lip definitely would be considered a high risk for metastasis. That lesion probably would measure over a centimeter, probably 1.2 centimeters if we had our little ruler out. And it's on a lip. And this might be a not just sun exposure, but also perhaps nicotine-induced squamous cell carcinoma. So certainly people who have a history of dipping or chewing tobacco or smoking, very high risk for oral squamous cell carcinoma. So part of skin exams on those patients is looking in their mouth and at their lips very carefully. So that patient on the bottom would certainly be somebody that once we confirm the diagnosis of squamous cell carcinoma, we would want the Castle Bioscience test to see what his genetic risk were for recurrence or metastasis. Again, another pretty classic example, you see that kind of keratin plug. That's because they are squamous cell carcinomas from the squamous keratinocytes, so they tend to make more of a crust or scab on the surface, which is basically just dead keratin from those cells replicating too quickly. Another example, this one probably would bleed easily if the patient scratched it, but superficial, we'll call that either Bowen's disease, because Dr. Bowen's put his name on that probably a century ago. And this would also possibly with the biopsy confirming superficial, meaning it had not invaded the dermis was still in the epidermis, could be treated with a variety of different treatment modalities. This one gets a little bit more complicated to diagnose because you can see it's kind of in this hair-bearing area, and the patient has a lot of sun damage with kind of this smudged pink area around it. But I would say we're kind of zooming in there with the photograph. That's the squamous cell that arose from the actinic keratosis. On the sidebar here, I've just listed some of the risk factors for squamous cell. I've already mentioned smoking as well as sun exposure. We do see more squamous cell with the aging population. I haven't seen a squamous cell in the 20-year-old age group yet, primarily basal cell and unfortunately melanoma. But immunosuppression, I mentioned, is a big risk factor, and not just for transplant patients, but a lot of patients who are on biologics, some of the other immunosuppressive treatments should be coming in for regular skin exams with dermatologists. HPV is definitely a risk factor. I have seen quite a lot of genital squamous cell carcinomas that were HPV related. And so when I have patients come in with condyloma acuminatum and they have HPV in the genital area, it's very important that we explain to those patients they do have a higher risk of developing squamous cell carcinoma. And we want to treat our HPV patients with topical immune therapy. Imiquimod is the prescription drug of choice because imiquimod does induce an immune reaction. It actually has 2 FDA indications, and one initially was for treating warts. And then we also realized that, warts and skin cancer act a lot alike. One is a virus that took over the nucleus, and the other one, skin cancer, is the nucleus mutated. But both scenarios, the cells replicate too quickly without control. So imiquimod's actually one of the first immune therapy drugs. Matter of fact, I think it actually is the first immune therapy drug that was FDA approved probably 15 to 20 years ago, but for topical treatment of genital warts. And then quickly it got also FDA approval for treating superficial skin cancers and precancers. So for my genital wart patients, they have to go through a protocol with immune therapy using imiquimod, not only to treat active HPV, but hopefully also reduce their lifetime risk of getting squamous cell carcinoma in the genital lesion area. And it happens. So I don't know, kind of what everybody practices here or what your role is in healthcare. But when patients present with anything in the genital area that is not healing, we go down that same differential diagnosis and rule out skin cancer. And it's not terribly uncommon for us to see that. So next slide. Now we're up to melanoma. I hope we're okay on time. Myra, are we doing okay?
We're all good.
Okay. It's a long talk. I'm a long-winded, so I hope everybody's not getting bored. Okay, so melanoma. As we've discussed, it's the 3rd most common skin cancer, but typically considered to be one of the very scary high-risk skin cancers. And primarily that's because these lesions are very much under the radar. And by that, I mean, it is so uncommon for anyone to come in to see me for a mole that they have noticed is changing. Oftentimes they come in for some other problem, and 90% of the time it's a seborrheic keratosis that's completely benign. But the melanoma lesions are usually going to be so delayed diagnosis if we're just waiting on people to notice changes themselves. A lot of times they're on places people don't even observe, like their back or their buttocks or, around their hairline. So as a dermatologist, it's extremely important when patients come in for a skin exam that we literally go head to toe, check the scalp, behind the ears, even in covered areas. I just took a lesion off a patient this morning that had a 1 millimeter jagged black macule on her left buttock, and she had not noticed it. But I also do dermoscopy, and I don't know if I have slides in this presentation. I hope I do. But dermoscopy is a tool that we use, or the dermoscope in dermatology, that is based on this light and lens system that magnifies the lesions. And then we can see subsurface features. There's all kind of patterns on dermoscopy that would indicate to me that a lesion could be either atypical, we call those dysplastic nevi, or already potentially a melanoma lesion. Or like another patient this morning, I zoomed in with the dermoscope and the pattern was perfectly normal. So that patient did not have to get a biopsy. But melanoma lesions are sneaky because we're literally only warning signs we get are visual, and it's variations of color, asymmetry, and irregular borders. A lot of information on this slide, just giving you statistics on people's risk and the number of melanomas that we typically see. These are, to me, blatantly obvious examples. And I would say in my practice, rarely does anyone have anything this blatantly obvious. These are usually the ones that patients do notice themselves or a friend or family member, and they come in. Most of the ones that we detect in my practice, this past year, we had probably 95% of the melanoma cases were in situ, meaning they had not become invasive. We called them before they got into the dermis, but the majority of those in situ melanomas were 2 to 3 millimeters in size. So the old lesion, which is still down here on this slide, is something we should definitely delete, because the old adage was a mole that was at least 6 millimeters in size. And in my practice, we remove multiple lesions that are anywhere from 1 to 3 millimeters and already catching them with early findings of atypia or early malignancy. And again, as I mentioned, those are the ones that are easy to cure because they haven't invaded the dermis, therefore no risk of metastasis. But looking for asymmetry, again, obvious changes on this top lesion, one side looking different than the other, variations of color, irregular borders. The one on the bottom could easily be also kind of mistaken for basal cell carcinoma, which wouldn't really matter as long as you did biopsy it. And then the asymmetry, the variations of color, anywhere from red, tan to pink and brown, any combination. Or I tell patients if they notice a lesion that just suddenly or gradually changes colors, they would want to come in and let me check that. Skin aging increases the risk for skin cancer. So of course, the more birthdays we've had, especially our seniors, as they get over 75, the immune system in general just kind of is ready to go into retirement. And the patrolmen don't really pick up these little DNA defects. And so we do understand that our seniors may be higher risk for skin cancer. But this day and age, I'd say in the last few years in particular, the highest percentage of skin cancer, new skin cancer patients are in their 50s to 60s. So again, if you grew up in the 60s or 70s, you really need to go get a skin exam. Pediatric skin cancer, I've mentioned quite a bit already about my 20-something-year-olds already coming in with skin cancers. But melanoma, thankfully, is rare in pediatrics, but it does occur. Thankfully, their cure rate and their outcomes are relatively good. But I do have parents who bring children in to see me all the time. We're looking again in the same exact warning signs with asymmetry, variations of color, or changes, and really monitoring the moles in children as well as adolescents, looking for early warning signs. Spitz-Nevis is one that we'll see in children, and it's a lesion that's still categorized as at risk but benign, but histologically, Spitz-Nevis can look very bizarre and atypical. It makes it hard for the dermatopathologist to say for sure it's not malignant, but the classic Spitz-Nevis will show up in a young child as a rapidly enlarging kind of reddish brown lesion. And typically we're just going to do the conservative excision so we don't have to worry about those lesions and monitoring them with just observation. So some of the increased risk and rates of skin cancer we've talked already about, what's putting us at risk. Again, our aging population, but going back to our youth, when all this starts in childhood with excessive sun exposure and sun tanning during adolescence, certainly has increased the risk in our population. Now we're going to just jump into treatment. So a lot of people have heard of Mohs surgery. When I was a resident back in 1990s at LSU, we were actually trained in the Mohs surgery technique. And basically that's a procedure where once we've identified the malignant lesion and confirmed it on biopsy to be a basal cell or squamous cell skin cancer, then the treatment would be surgical excision. If we're choosing surgery, and I'll tell y'all more about the non-surgical options. But Mohs surgery basically just replaced wide, deep excision where you didn't have margin control. Prior to Mohs surgery, when cancers were excised, they were excised again with wide, deep margins, and specimens were sent to pathology. And a week later, you'd find out whether or not your margins were clear. So with Mohs, we were trained, and this is typically the technique that's still utilized today, to excise the lesion. We'd start with about 3 millimeter margins, excise down to the subcutaneous fat. In my practice for 20 years, I would basically send it over to my dermatopathologist. And while I was still seeing other patients, my pathologist would be checking the margins. A lot of most surgeons who only do skin cancer surgery have their labs set up in their practice with the histotech. And basically, again, once they excise the lesion, then it's processed and they look under the microscope to see if the margins are clear. If there's an area where you still see the tumor extending out to the margin of the excision, then you have to go back to that section and excise more. So we call that staged excisions, where we're doing the histology in between the staging to confirm that the cancers are completely clear. Once the margins are clear, then the next challenge we have is to close the wound. And a lot of these skin cancers are on cosmetically sensitive areas of the face, so eyelids, nose, lip, and or ears where there's no loose skin at all. So our techniques would involve using flaps or grafts to close those wounds. And I did that for the first 20 years of my practice. In 2019, I was attending one of my medical meetings that I was lecturing at in Nashville, and it's a very good dermatology meeting where lots of things are, brought up with newer trends and newer treatment options. Back in my residency training, we did train not only in the Mohs surgery technique, but in radiation therapy. Back then, there was a large kind of contraption, this big booth that we had to put patients in. Of course, it's a teaching hospital, so they could offer that type of technology. But going into practice, really, we didn't have any way to bring X-ray therapy into a clinical office setting. But in 2019, while attending this meeting, I heard a lecture on image-guided superficial radiation therapy for treatment and cure of non-melanoma skin cancer. And so over the past 10 to 15 years, a company called Census had these engineers and physicists working on how to bring in the radiation technology and a device that looks more like a laser. And they added what's called image guided, which is ultrasound guidance. So we could now visually see the depth of the tumor without having to cut it out and go look under the microscope. So since we were really experiencing such a high increased incidence of skin cancer, lots of patients of different ages, I thought this was a brilliant technology to offer patients to cure skin cancer without surgery, especially those who are poor surgical candidates, which consist of anyone from a diabetic or someone with AFib who's on blood thinners, or again, some of these immunocompromised patients that make them at higher risk for infection with surgery. So in 2019, I started incorporating image-guided superficial radiation therapy into my practice to give my patients an alternative to surgical excision, where we were replacing cancer with scar tissue. With radiation therapy, we're curing cancer by destroying the cancer cells and letting healthy skin repopulate the area. So again, Mohs surgery, I've just explained how we take these layers and progressively remove tissue until we're cancer-free. And then again, using surgical techniques with flaps and grafts or even primary closure to close the wounds. Some of the risks I've listed here are, complications that can occur, which could include bleeding, poor wound healing, and sometimes scars that lead to disfigurement, especially around the nose or the lip or the ear. Benefits, of course, with Mohs surgery are high cure rates in the 96% or higher, 94 on this slide, but I think we've moved up to 96. This is a classic example of Mohs surgery with a full thickness skin graft on the nose, and you can see the gentleman did heal well. These are some other examples of some surgical excision results with Mohs. And then this is the device that is referred to as image-guided superficial radiation therapy. We're using low doses of X-ray therapy, so this is not the same type of radiation that's used for prostate, lung, or breast cancer. Those are E-beam radiation devices that can go deep into tissue. This device is literally for skin cancer. It's skin deep, so the term superficial meaning skin deep. And these are FDA-approved devices for treating the non-melanoma skin cancers, which would be the basal cell and squamous cell carcinoma. The other indication in use is for keloid scars, and it works beautifully to literally cure keloids, where the dermal fibrous tissue is out of control. We can literally do a shave to take down the keloid or an excision to remove it, and then we use 3 doses of X-ray therapy to cure keloid. For our skin cancer patients, it is 20 treatment sessions, and we space those out where they come in 3 times a week over a period of about 6 weeks. Again, we call it gentle cure because we're not using anything surgical. There's no wounding, and patients will have an excellent outcome and an extremely high cure rate that has now been the last report up to 99.3%. With IGSRT, I can treat both superficial and invasive squamous cell and basal cell carcinoma to achieve that 99.3% cure. And the great thing is, after we treated them, we're not hoping we cured it, because the ultrasound does allow us to see visually that we've completely cleared the cancer and replaced it with healthy tissue. I'm just going to cut through some of these slides. Okay, this is an example of a patient at biopsy. During the treatment, the red scaling, peeling, and then afterwards the skin's nice and smooth. Another example, a biopsy on the shin of a leg, which legs are very difficult to heal from surgery. So a lot of my patients with skin cancer on the lower extremities choose to do radiation therapy instead of having to go through surgery. Great example on this patient's nose, where the basal cell is the inside of the purple circle. The outer purple circle is the margin. This is at the final treatment where the skin is red and scaly, and then they heal with nice, smooth, healthy skin. And again, a few more examples, this one being on the tip of the nose, where Mohs surgery is somewhat more complicated because there's no loose skin, and this often results in a flap or a graft with surgery. And instead, we just cured this and allowed the patient's skin to heal with its own healthy tissue. And I mentioned the keloids already, a great example where this keloid had basically just involved the entire inferior and posterior helical rim. And after a shave debulk, treat with radiation therapy, and it healed without recurrence. So in conclusion, we need to be on the lookout for skin cancer. We need to educate our patients more on sun protection, starting at really early young ages, like childhood. And again, I recommend people certainly seek out skin exams at least annually. And I do recommend full body skin checks, not just having patients point out the lesions they're concerned on, but actually looking for ones they may not even realize exist. So I hope I was able to give y'all some helpful information and at least a little pearl of wisdom or two to take home back to your practices and home with you. Thank you.
Thank you. We do have some questions.
Okay.
What type of SPF do you recommend?
The latest data on SPF protection is at least a 30. And if you've had a history of skin cancer, the recommendations are now that you use a 50. So increasing, the SPF, it only increases a slight amount. The numbers go from 30 to 50, but the degree of protection's not, twice as much. The most important thing with sun protection is to use at least SPF 30 or higher and apply it daily, but reapply throughout the day. And especially when you're outside sweating or swimming, that you reapply at least every hour and a half. I personally, as a dermatologist, recommend mostly mineral sunscreens. I like the zinc and titanium dioxide because they give us really good protection, and it avoids the chemical exposure that people are worried about, not only for our environment with the coral reefs, but also just with our general health and chemicals in general.
Okay, and we have another question. Can you explain why you recommend, is it niacinamide D3?
Yes, I can. Oh, yes. Somebody might have heard me talk about that a lot. So there was a study out of Australia several years ago. They took 2,500 patients who had a history of skin cancer, and they had them start taking vitamin B3, in particular, nicotinamide was the form of B3. And then they had a control group of another 2,500 skin cancer patients. And after a year, the ones that were taking the vitamin had 23% less new skin cancers. So from that study, more studies have been performed, even in the United States. And the benefit with B3, either niacinamide, which is typically in a topical formula, or the nicotinamide oral 500 milligram dose twice a day, is that it's upregulating DNA damage. So that has been shown to help reduce our risk for skin cancer, because when we're taking those supplements and even now incorporating them into our skincare, we could actually help fix some of these DNA glitches, and again, hopefully mitigate those cells from progressing into skin cancer.
How often would you say that we should go to a dermatologist to be checked, or also about checking ourselves?
Yeah, I think at least once a year, people should be getting skin exams. Again, just like going to your dentist, getting your dental checkup, your skin exam checkup yearly. And if I've got high-risk patients, and I have a lot of high-risk patients, the patients with 50 or more moles, a family history of melanoma, I've got them coming in every 6 months. We do photography on patients with multiple nevi. I had a lady in yesterday, she probably has well over 100 plus moles. And so I use her pictures to compare to what I'm seeing on that appointment. And then I encourage patients to also take their own pictures, or we'll share the ones we have, keep it in their little secure album on their phone, and actually use their photographs to monitor their moles as well. So we recommend that people do monthly skin checks on themselves, or they just kind of stop and look and see what's going on with their moles. And again, if they've taken some baseline photographs, either we do it here in the office for them, or they've got a trusted person at home to take pictures of their back or their legs, we just photograph those areas, and then patients can use those pictures to more closely monitor. People say to me all the time, Myra, that, I can't tell if it's changing. I look at it all the time. I don't know if it's bigger, or my husband's looking at my back, but he's not sure what to look for. So again, using some, baseline photographs and, coming in for those exams so we can catch things early. My skin cancer patients, we pretty much have them in every 6 months. And some of them who are at higher risk, it's even every 3 to 4.
Okay, thank you. We have another question. Do you see a lot of children with skin cancer?
No, thankfully, we see a very low number of skin cancer in children. I have had teenagers with melanoma. I've had young children, pre-adolescents, with atypical nevi, and then some of the Spitz nevi. But I do have quite a lot of little kids that will monitor moles, especially if there's a strong family history. We'll check them at least once a year. And then ones that look atypical, I've had even the young babies who had congenital nevi that already had atypical features, and we just do excisions, so we don't have to monitor and worry about those at all.
Is the image-guided radiation therapy covered by commercial health insurance plans?
Yes, it should be. Almost all of the commercial insurance plans will cover it. I've only had a few patients, just perhaps it's their policy with a high deductible, where they didn't have optimal coverage, but Medicare patients for sure have great coverage. We had to convince Blue Cross that it's a medically necessary procedure, and it is covered, again, by most all the commercial insurance companies at this point.
Okay. I think that's all of the questions. We appreciate you doing this today. I myself have been very bad in the sun in my younger days, and so I found it very educational, and I feel like we all need to run out and make our appointments and get checked.
Yeah, if there was ever baby oil and iodine and a bathing suit, then you need to get your skin checked for sure. Yeah. All right. Well, thank you all, and I appreciate the opportunity to come on this webinar today and just kind of educate and share my knowledge on skin cancer. And again, I hope everyone found some benefit in this today. Thank you, Myra.
We have someone that says, awesome presentation. Thank you so much. And she'll be calling your office.
Well, thanks. I appreciate it. All right. Well, y'all have a great weekend. Thank you.
You too.
Bye-bye.
Bye-bye.